Hi, I am Adrian Palmer, registered physical therapist, and with me is Alina. Today, we'll be demonstrating an orthopedic assessment of the shoulder. Before we get to the shoulder, it's always good to ensure that the pain in the shoulder is not originating from the neck. Alright, so we're going to do a quick screen of the neck. What I want you to do, bring your chin down to your chest for me. Good, and bring it all the way back up. Nice. Lean to the right and lean to the left. Good. Rotate to the right, rotate to the left, and look back forward. Pain with any of those movements?
No.
Alright, good. We could also do a foraminal compression. Any pain with that?
No.
Good. We could also move on to do Sperling's test to rule out any form of cervical radiculopathy. Nice. Any pain?
No.
Good. Stand up for me. We could also palpate along the neck to ensure that there is no pain or anything like that. Any tenderness along here?
No.
Good. So we could go paraspinally as well on both sides, coming down. Good. Any pain?
No.
Very good. Now you could have a seat. Nice. After clearing the neck, we'll then move on to assess the shoulder by observation and palpation. So in looking from the front, we're trying to look to see if we're getting normal alignment. The only thing we notice right here is just that the right shoulder a little bit lower than the left. We're looking also along the clavicle region to see if there's any deformities or anything like that. Nice. We'd also move then to do some palpation. So normally I would start at the sternoclavicular joint. Good. Any pain along here?
No.
And then we palpate along the clavicle to ensure no deformities or nothing like that. And we come straight up to the acromioclavicular joint. Any pain?
No.
Good. We also want to find from this position the coracoid process. Any pain here?
No.
Good, because here we have the pec minor and also the short head of the bicep inserted. We'll also move along to the anterior shoulder in the bicipital groove to palpate for the long head of the bicep. Any pain here?
No.
Very good. And we could also palpate for the pec major tendon. Just pull the shoulder to your side for me. Pull it to your side, no, like this. To your side, like this. Pull it to your side. Good, and relax. Good, pull again. And you feel the tendon jump out at you. You could palpate it there. Any pain there?
No.
Very good. Stand up for me and look towards that direction. So now we're looking at a lateral view. In the lateral view, we could take a quick scan to look at the C-spine to see if we're getting that normal curvature. And then we'd also look at the thoracic spine to see if we're getting that normal kyphotic posture that we should get at the T-spine. We could also look at the shoulders to see if the shoulders are sitting forward too much, if they're rounded, or if they're in a neutral position, and we're getting alignment of shoulder, ear, hip, etc. We just see where the head is a little bit forward compared to where the shoulder is. Nice. Also, in this position, we could look to see if we're getting anything like a sulcus sign or anything like that. Then we'd move on to do some palpation of the subacromium area. Any pain there?
No.
Once we don't have any pain there, we could also ask her now to face forward and we'll observe from posteriorly. In observing posteriorly, we want to look at the spine to see if we're getting a normal alignment of the spine. So when we reach to the thoracolumbar ear region, we could see we have a little bit of curvature coming towards this side. And then from observing that, we could look at the shoulder blades and we could see where this one, is just pushing back a bit and it's a little bit lower compared to this if we look at where the inferior angle of the shoulder blades are. Nice? And we could also observe the distance from midline and compare them in this position as well. Right? And then we could also move on now to do further palpation. I like to do along the spine or the scapula. Once no tenderness there, we come to over the supraspinatus and also the upper traps region and check to see if there are any tenderness. Any tenderness?
No.
Good. And then we move. I like to check all as well the posterior shoulder itself along where the external rotators of the shoulder is running to see if we get any tenderness in those areas. Any tenderness?
No.
Good. Seeing that we have completed that now, I want us to move to look next at some range of motion. Right, so face forward. So let's look at flexion and extension. So raise your arm up in front of you, all the way up, and back down. Continue for me. So up, nice, and then all the way back, all the way back, all the way back, all the way back, all the way back. Come all the way back. Good, and then forward. Nice. So in the coming up into flexion, we want to see if we're getting extension at the thoracic spine, which is normal. And additionally, we want to see if we're getting that upward rotation of the scapula, which we are seeing here, which is good. All right, thank you very much. Nice. After completing that now, we'll ask the patient to face forward. So now facing forward, just put your arms up like this on me, and then rotate your arms up. So looking at external rotation, far back as much as you can. Good, then under now, which is not bad. Bring your elbows to your side and rotate the shoulders out. I like to check from this position as well to compare the movements. That is very good. And then relax for me. Next we'll move on to check is abduction and adduction. Bring your arms up like this for me and then back down through the sides. Good, continue. So we're getting full range of motion. Additionally, I would want to see if there's a drop arm sign anywhere throughout the range when you're assessing a patient. And additionally, we could also ask the patient if she's experiencing any pain at any point during the movement.
No.
Good. All right, turn and face the wall for me. If the patient is experiencing pain throughout the movement or at specific angles, then we could see if we're getting a painful arc. And we'll ask the patient to indicate where she's experiencing that pain. And then we'll ask her to do the movement again. Go to the side and back down. Back down. Good. So we could do a scapular assistance test. Up again. And back down. Good. Up again. And back down. If there is no pain or reduced pain with the scapular assistance test, then we know that the pain could be as a result of impingement in the shoulder secondary to weak scapular muscles. Alright, so next thing we could do from this position is to see if we're getting good scapular rhythm or coordination between the scapula or the scapular muscles, right? So shrug your shoulders up to your ear for me and back down. So we're looking to see if they're moving together. Continue to see if they're moving together or if one is moving slower than the other, if one is resting lower, one is reaching down later than the other, that kind of thing. Alright, push your shoulder blades forward and back. Good, and then back and squeeze. And we're looking for same thing to see if we have, continue, to see if we have harmony in the motions. We could additionally ask the patient to do a wall push-up. Could go around and do a wall push-up for me. Nice, and out, continue. And we're looking to see if we're getting any winging of the scapula, which could indicate as well serratus anterior weakness or weakness in the lower traps muscles. Right? And relax. And come back around here for me. So what I want you to do next is to have a seat. So after we finish assessing the scapula, observing range of motion, all of that, we could move to do some resisted isometrics. Resisted isometrics help us to know whether or not the pain is as a result of injuries to the nerve, the muscles, or the tendons. So we're looking for whether we're getting a strong and painful, weak and painful, or weak and painless, or something like that. And it will indicate to us whether there is nerve injury or muscular tendon injury. So keep your arm in a neutral position, right? Don't let me move it. You just keep it right there. So testing shoulder abductors. Any pain?
No.
Adductors, any pain?
No.
Good. Extensors, any
No.
pain? Flexors, any pain?
No.
Good. Internal rotators, any pain?
No.
External rotators, any pain?
No.
Good. And we could also check the bicep as well. Any pain with that?
No.
Very good. So after we do our resisted isometrics, we could move on to do some specific, quote-unquote, special tests for the shoulder. There are common areas in the shoulder that are normally injured, and those are the areas that we'll cover in today's assessment. Let us first look at the acromioclavicular joint. So we'll do the crossover test. Any pain?
No.
This test normally compresses the acromioclavicular joint and would cause pain if that area is injured. We got no pain. It's good to do each test on both sides for comparison. Let us move on now to test for biceps and slap lesions or pathologies, and our 4 tests that I normally do. First one would be the speeds test. So lift your arm up like this for me. Hold it in this position and don't let me move it. Hold. Any pain?
No.
Very good. Then let's go and do the Yergerson's test. Good. So you're trying to turn your arm out, but I will resist you. Ready? Let's go. Turn it out. Turn it out like this. Good. Any pain?
No.
Very good. And additionally, we could palpate for where the head of the long head of the bicep is. Ready again? Resist me. Nice. And you could feel if the tendon is jumping out at you, and that will indicate damage to the structures that hold the long head of the bicep in place. Next test we can move on to do is the O'Brien's test. So we'll have the patient abduct the shoulder and internally rotate. Nice. Hold it in this position and resist me. Good. And then we could ask them to turn up next and resist again. If the patient experiences pain when the thumb is down versus up, then that will indicate injury to the superior labrum. Additionally, we could also do a shear test and see if we get any form of clicking or anything like that in the shoulder, which could also indicate some form of slot lesion or pathology. And we didn't. We could move on now to check for impingement and have two tests that I normally do: empty can and Hawkins Kennedy. The empty can, hold your arm out like you're holding a can of Coke and turn it down like you're pouring out everything. Very good. Hold it in that position for me. Any pain?
No.
Very good. And relax the arm. And then we move on to do the Hawkins Kennedy. Good. Any pain?
No.
I normally do this at various angles and coming across the shoulder to see if it's producing any pain. Any pain?
No.
Okay, very good. And then we have no problems with impingement. The next thing we want to move on to check for is instability or ligamentous injuries to the shoulder. But before we do that, it's good to check if this patient is normally hypermobile in other joints. So we could do that by looking at the fingers. So we could see where she's a little bit flexible here. And it's always good to compare sides. Nice. We could look at the elbow. Alright, not so much at the elbow. Nice. Could you stand for me, please? And face the right. So we could assess from this position now. We could look for a sulcus sign, which could indicate inferior instability of the shoulder. So looking to see. So good. And we're not seeing anything there. Next thing we could do is a load and shift. Push forward and pull back. Push forward, pull back. And no complaints of pain? No?
No.
Good. Right? And also, if you come up like this, we could do an apprehension test. Nice. So put it in the apprehension position. This is the position that most dislocations normally occur in. And from here, we'll give an anterior force to the head of the humerus and to see if the patient becomes apprehensive or complains of pain to indicate a positive apprehension test. And nothing. Very good. You can have a seat here. So now that we have done all our special tests and everything, the next thing we could move on to do is get an idea of muscle strength, so we could do some manual muscle testing. So lift your arm up for me. So let us check the shoulder flexors. Hold in this position. Very good. To the side. Shoulder abductors. Hold. Very good. Nice. Lie on your stomach for me, please. Then we move on to check shoulder extensors. Lift the arm up. Hold, don't let me move it. Just a little bit of weakness there. And then we can move from here. Lift the arm up. Good. External rotators. Nice. Then come under. I'll check the internal rotators. Very good. And relax. Nice. You can sit up for me. And there we have done our assessment of the shoulder joint.